Almost ready. All right, looks like 8:15, so we are going to get started because I got some ground to make up. We need to get through the rest of our cardiovascular chapter. We need to get through most of the immunology chapter, immune system chapter, and set us up so we can finish respiratory on Thursday, since our next test is a week from today. So I'm just going to jump in where we left off last time as far as blood volume, blood pressure control is concerned. So in order for us to maintain good blood pressure in the body, we need to have a sufficient volume of blood. And so we've got a couple different hormones that function at the level of the kidney primarily that help us to do that. The kidney's in charge of basically deciding, along with the hypothalamus, if our blood is too concentrated, too dilute, if there's a buildup of too many ions, a buildup of too many waste products, and basically trying to figure out what it needs to get rid of to maintain homeostasis and what we need to kind of hang on to. So we're going to talk about two different hormones that act on the kidney that are basically going to largely make the kidney hang on to more water, is their primary role. So these are things that are released in response to lower blood pressure type situations. So the first one is ADH, antidiuretic hormone, and the name tells you what it does. It prevents us from becoming too diuresed, and diurese means to lose fluid, basically. So it's going to make us act to hold on to water, and ADH is going to be released based on concentrations of ions increasing in the blood. So we've got two kind of different scenarios where that could happen. Either we're very dehydrated, we've been, let's say exercising in the heat, doing yard work all day in the heat, and lost a lot of volume through sweating. That's a situation where our body's like, okay, there's too many salts in our blood. We've lost too much just pure water out of our plasma. So we need to hold on to just water exclusively so we can decrease the concentration of those different salts, the sodiums, the potassiums, calciums, different ions that we have in our bloodstream. The other scenario that could cause ADH to be released would be not where we're necessarily dehydrated, but that we've introduced way more salt into the body. So I open up that big 2-pound bag of tortilla chips, sat down to watch a football game, and before you knew it, I ate like half that bag. And so I've just taken in just tons and tons of sodium into my body. And so now the body's like, okay, now my blood has way too much sodium in it as those things are getting absorbed through our gut. And so the body's like, we need to dilute that or we're out of balance. So that's a situation where we'll kind of create a volume overload. If we just introduce salts, we still want to dilute it. And that's the kind of scenario where you might feel kind of puffy. You'll start developing a little bit of edema because essentially you've got too much fluid in the body. So the dehydration situation, we wouldn't necessarily see that. We would basically be just trying to bring in enough water to kind of get us back to where we want to be as far as our blood volume is concerned. In the situation where we add in too much salt, it's going to be the opposite. We might have been doing fine as far as our total blood volume is concerned, but by adding a bunch of salt into our bloodstream, it makes us want to hold on to a lot of water. So either of those situations, our hypothalamus is going to sense that imbalance in those different ions that are raising in the bloodstream. It's going to tell the posterior pituitary, where we release that ADH from. Again, the hypothalamus produces it, but the posterior pituitary is going to release it. And so when it releases it, it's going to basically make the kidney, the nephron itself, hold on to more water. So it won't let as much go into our urine and will overall end up increasing our blood volume. We'll also get a stimulus in our brainstem, essentially, where our thirst receptors are, that are going to tell us to drink too. So we'll have this sensation of being thirsty. We'll feel dehydrated. We'll feel like we need to drink fluid. So it's kind of this twofold thing. Hold on to what we can at the kidney, but also take in some more to kind of help increase that volume as well. So both of these are low blood pressure situations. And when people suffer from high blood pressure, a lot of times they're going to take diuretic medicines like Lasix is the most common one that's going to basically counteract the effect of ADH. Your body is trying to release ADH to keep your blood volume at a certain level, but if the doctors are more concerned that your blood pressure is too high, we want to negate the effect of that by giving you something else that's actually going to make the kidneys let more water go. So that's kind of the trade-off on that. It doesn't always work perfectly, and when people have high blood pressure, that can be one reason why. The other hormone that affects the kidneys is aldosterone, and this has more varied actions. It acts upon both the blood vessels and the kidneys, and it does so a little bit differently. Instead of making the kidney want to hold on to water, it makes the kidney want to hold on to more salts. And so when we hold on to more salts in the body, then we are going to draw fluid to basically try to make sure that our blood osmolality stays appropriate. Um, so we get a more proportional increase in fluid and volume because it is matching basically the sodium concentration. So we tend to be more isotonic when aldosterone is working. We basically reabsorb the appropriate amount of water to match however much sodium we're hanging on to. Whereas in the case of ADH, we're just taking in water. So we're basically going to become more hypotonic when we start releasing ADH compared to where we were. Most of the time we're releasing ADH because we've become hypertonic and we're trying to dilute that. But aldosterone is going to work differently because it's got this kind of hold on to salts. If we hold on to salts, then the water will be drawn to the salts because of that osmotic pressure that we see. I'm going to skip ahead to this flowchart slide. So what's going to happen with aldosterone is it's not really the primary hormone that causes the effects, but it causes some changes in the body that make the active hormone work. So low blood pressure, our kidneys are going to sense that, hey, we're not getting a lot of blood flowing through us, so we need to do something to improve that. It has its own built-in sensory mechanism, kind of like the hypothalamus is in charge of sensing those things too. In this case, it's purely the kidney itself figuring things out. So the first thing that gets released is renin. And renin is released from the kidney. It's going to act upon a precursor hormone called angiotensinogen. And the renin converts angiotensinogen to angiotensin 1. Once we get to angiotensin 1, there's another enzyme, this ACE, that stands for angiotensin converting enzyme, that converts the angiotensin 1 to angiotensin 2. Angiotensin 2 is now the active ingredient that is going, or the active hormone that's essentially going to act on the adrenal gland right on top of the kidney and specifically target the cortex cells, so the ones on the perimeter, and that's going to release aldosterone that I mentioned earlier. So aldosterone is going to work on the kidney to make it hold on to salt. Because we hold on to salt, then it also draws water in, and both of those things are going to lead our blood volume to go up. At the same time that's going on, angiotensin 2 also works as a vasoconstrictor. So we're trying to raise blood pressure, and we're doing it basically two ways. Add some more volume to the system so we can increase the pressure in the system, but also tighten up the vessels so we can also increase the blood pressure. And so this has, again, more multiple effects than just ADH does. And it's a process that's easier to block. We don't run into a situation where we just give another medicine to counteract the effects of ADH like we would with Lasix. In this case, what is most commonly done when people are having high blood pressure that they're trying to control the release of aldosterone with is there's a whole class of medications called ACE inhibitors. So an ACE inhibitor is basically going to block the effect of that ACE enzyme and will never create angiotensin 2. If we can just have the kidney release renin, it acts on angiotensinogen, converts it to angiotensin 1, and the whole process never proceeds beyond that, then we're never going to see aldosterone get released. We're never going to see vasoconstriction of the arterioles. We're never going to see the body hang on to the salts and the extra water. And so that's a pretty common blood pressure medication that you'll hear about patients being on. So if you ever see an ACE inhibitor, that's the purpose of it. It's to stop this step right up here, kind of midway through this slide, so that everything after it cannot take place, or cannot take place in as large amount as it would otherwise. Blood pressure can be really hard to control, and they'll try different combinations that target different parts of these regulatory mechanisms to try and get things under control. Sometimes we target the heart so it doesn't beat as hard. Sometimes we target the kidneys so we lose more fluid. Other times we're trying to block the effects of some of these hormones.
So quick question. Is the reason you shouldn't exercise within, I don't know, 5 to 10 hours of donating plasma, the decreased blood volume?
Yeah, I mean, you're definitely low on your red blood cells and things, but it takes a long time to ramp that back up. But the blood volume, just hanging on to fluid, then we can change that pretty quickly. And so they will typically want you to drink something before you leave the donation center or the donation bus or whatever the case might be, and kind of lay low for a while so that your kidneys have a chance to kind of bring that volume at least back up a little bit. You're still going to be short on red blood cells, so your oxygen delivery is going to be impaired, but you're going to have less problems with like dizziness and potential, especially if you try and exercise when it's hot. If you've already lost a lot of blood volume, then you don't have much ability to produce much sweat, and you can run into overheating problems a lot easier than that too. So definitely a wise decision to lay off exercise, at least for a period of time. The other option is that you've just been stuck by a needle, and so where that clot formed is maybe not totally secure, and so if you go start exerting yourself, then you might actually start bleeding again from that site. You know, it's a vein, so it's not that hard to make it stop, but that's another risk, especially if you think about something like resistance training, where we tend to strain and bear down a lot, especially if we're moving a higher weight. Then that can kind of increase that internal pressure that might kind of blow that clot out of the vessel that got poked.
Yeah, that's a good point.
But I think the bigger reason is, like you mentioned, just the overall fluid volume compensation that we're trying to let happen.
What are non-pharmacological approaches to controlling blood pressure?
Decreasing sodium intake is probably the simplest one. And there's a certain group of the population that has high blood pressure that are very sodium sensitive. So any little addition of sodium to their diet will make them hold on to a lot more water and raise that pressure up. And so those patients in particular, if they really try and reduce their sodium intake a lot, can get pretty good results non-pharmacologically. The other side of things that can kind of help is just trying to reduce people's sympathetic nervous system overactivity. So if we can do things like relaxation training, things that reduce stress levels, improve coping strategies, things like that, that just lower your overall stress level, then you're going to tend to release fewer of the norepinephrine and epinephrine that can also cause a lot of vasoconstriction and extra force of cardiac contraction and things like that. So that's another pretty simple non-pharmacological way that you can potentially impact blood pressure. All right, so this slide has kind of a lot of information on it. The main thing that I want to focus on is kind of down at the bottom, and then these two comments in the middle. When we have vasodilation, if we open up more blood vessels or make the blood vessels that are open even larger in diameter or in the radius, then we can really reduce the amount of flow or increase the amount of flow, because we have much less resistance if that diameter is a lot bigger than it used to be. If we have constriction, then we have just the opposite. We're going to make that vessel very small, and it's going to increase the amount of pressure in there. And that will basically, that's how the body figures out where to drive blood flow. When we look at the sympathetic nervous system activating, we want to drive blood flow to the muscles. When we look at the parasympathetic system activating, we want to cut off blood flow to the muscles and kind of drive it more to the gut so that we can help those organs do their thing. And the biggest determination of where blood is going to go in the body is that radius. How big around is that vessel? And we look at the formula down at the bottom here. This big R here is not for radius, it's for resistance. And so that is how much resistance is there to the flow of the fluid, in this case blood. And so how long the vessel is plays a role in it. If we're talking about a short vessel going from the heart up to the brain versus a long vessel going from the heart all the way down to the big toe. Those are very different lengths of blood vessels. And so you're going to have more resistance the larger that distance is. How thick your blood is going to play a role. So if we're in a situation where we're more dehydrated, then we have a higher relative concentration of the formed elements, the red blood cells, the platelets, the white blood cells. And that makes our blood more closer to like a gel as opposed to like a more of a fluid. And it's easier to move something that's less dense and more and thinner than it is something that's thicker or more viscous. So that plays a role too. But we multiply those two factors and then we divide it by the radius to the fourth power. And so that's a huge factor. Essentially, we're multiplying it many times over. So we have a much bigger influence on how much resistance to blood flow there is based on what that radius is. And that's strictly how much constriction we have going on, how much dilation we have going on. And so here's a kind of a good example to help you understand how big of an influence it means to multiply something to the fourth power or divide it by the fourth power. So in this top picture, we've got this artery, and it's flowing along from right to left. It's going to split into two smaller arteries. And in this first example, they're saying that the radius is exactly the same between these two new vessels that are being formed. So if the radius is 1 millimeter across, then in this example, the resistance is going to be just equal to R. The flow is going to be just equal to F. Now, if we have a situation where, let's say it's a sympathetic nervous system response, and this upper branch is going to go to the muscles, and we want to be able to deliver a lot of blood to our leg muscles so we can flee. If we double that radius from 1 millimeter to 2 millimeters, which isn't a lot, we just think about doubling it, we're going to have 1/16 the amount of resistance that we had before. And we're going to have 16 times more blood flow just simply by doubling that radius. 16 times more blood flow. That's what the fourth power does to it. If we look at the other situation, we decided we don't need blood going from the gut because we're worried about fighting off this invader. We're going to crimp down and narrow down that vessel. It's going to make it a lot harder for a lot of blood to flow through that vessel, and fluid is going to follow the path of least resistance. It's a lot easier to flow into this big vessel than it is to flow into this smaller vessel. And so we see the exact opposite dynamic. If we shrink that diameter, or excuse me, that radius in half from the original 1 down to 0.5 millimeters, now we have 16 times more resistance to blood flow, and we're only going to have 1/16 the amount of flow that we actually had. So a small change in the radius has a very dramatic effect on where that blood's going to go in the body. And again, if you've ever had a water leak in the house, you know that water finds a way. Wherever there's the least resistance, that's where that water is going to go, and blood's going to work the same way. So when we have dilation, blood flows like, hey, that's great. Look at that big, huge opening I can flow into. But when we have constriction, it's like, okay, well, that door, it's really hard to squeeze through. Let me go through this door that's wide open. It's a lot easier to get through that space. And you know, the length of the vessel plays a role, because as blood is flowing through the vessel, where the blood is in contact with the inner lining of the vessel, you kind of have more friction. And that's going to kind of create this drag as that fluid is trying to move through there. In the middle of that blood vessel, where the blood is just moving against itself, then it's easier for that blood to kind of flow past its own types of molecules. If we think about water molecules and things like that, there's not the same kind of friction. So the narrower that vessel is, proportionally, there's a lot more blood coming in contact with the walls and creating this extra drag and this extra resistance to flow. So there's a number of different reasons why that radius diameter, or that radius is such a huge thing to regulating blood flow in the different parts of the body.
Hey, Craig, I have a question about that. So whenever you get blood drawn, does the diameter have a difference on what could happen if that gets punctured?
Well, so like if they try to stick a small vein, sometimes that will clot off. If you're not maintaining a high enough flow into the, like say you're donating a unit of blood, if they're in a smaller vein, then the amount of flow going through that vein is less. And so the pressure trying to drive the blood through the needle and into the reservoir that you're containing the blood is going to be harder to do. And the slower that blood flow is, then the easier it is for things to start sticking together and forming clots. And so sometimes you'll have a situation where the needle that's, pulling the blood out of the person's vein clots off and you lose that blood flow. Whereas if you're in a big, huge diameter vein, it's a lot easier to keep that vein open and that whole donation to take place before the clotting mechanism has a chance.
Okay.
Think about like if you have something like you dumped out, like say pancake batter that was left over at the bottom of the container into the sink. If you just put a trickle of water on it, it's really hard to wash all that sticky pancake batter down the drain. But if you pull that faucet on full blast with a higher flow rate, then you can much easily, blast that extra sticky gunk out of the sink and get it down the drain. So that the
Gotcha.
volume of blood is going to make a big difference in how easy it is for things to clot. And the slower the blood flow, the more likely it is to clot and cause some complications.
Okay.
All right. So the main place where we really control blood vessel diameter is at the arterioles. So we go from the big aorta and start splitting off into pretty large vessels, the ones that we think of as being named blood vessels, the brachial artery, the radial artery, the femoral artery, things like that. As it goes smaller and smaller, that's where we actually start seeing blood vessel shunting take place or blood flow shunting take place. So it's not really in the big arteries that are named. It's not really in the capillary beds. It's really the vessels that are leading to the capillaries is where we're going to either crimp down or cause a lot of dilation. All right, TPR, total peripheral resistance, has a lot to do with blood pressure and blood flow. And it's basically a sum of how hard it is for blood to flow through the vascular system. And so we have things like atherosclerosis, where our vessels are clogged and narrowed and our vessels have gotten stiffer. Well, that's going to create increased peripheral resistance. And then anytime we have a lot of vasoconstriction going on, that's going to cause an increased peripheral resistance. One of the big side effects of nicotine that people that smoke or dip or chew get is that nicotine is a very potent vasoconstrictor. So regardless of what's going on in the body, whether you're exercising or sedentary or eating or whatever, overall, you're going to see higher blood pressure and smaller blood vessels because of the effect of nicotine. And so that's just one example of things that can affect that total peripheral resistance. Again, it's how hard it is for the blood to flow throughout the body. And that can create problems on the heart. When people have chronic high blood pressure, they tend to have more peripheral resistance. Their vessels are crimped down or they're stiffer and not as flexible and not as compliant. And so that drives blood pressure up and it puts more load on the heart because the heart's got to pump that much harder to push the blood out against that higher amount of total peripheral resistance. So when you are mentally stressed, you're going to tend to have more total peripheral resistance because you're going to tend to have a little bit more sympathetic activation that's going to tighten up the blood vessels to the rest and digest type organs because we're trying to just see, well, am I about to use those muscles to get out of this situation? But when it's just mental stress, we're not really in a fight or flight scenario. We can still get that elevated blood pressure because of that constriction. When we're going to exercise, we will often get an increase in sympathetic activity. And that's especially true if you're going to do like a competition. You get that nervous, anxious feeling, game's getting ready to start, butterflies in your stomach, sweaty palms, all those kind of side effects. That's when we're most likely to see big releases of sympathetic activation. Even if we're just deciding to go to do our workout, we'll still get a little bit of bump in that. It's a non-competitive thing. I'm just going to go ride the bike for an hour or whatever. You're still going to have a little bit of rise in sympathetic activity. So initially we see this whole body effect where all the vessels that are receptive to that norepinephrine and epinephrine release will respond to it. And we'll see dilation to the skeletal muscle blood vessels. We'll see constriction to most of the rest of the body. And they have different receptor types, and that's why they kind of work a little bit differently that way. Once we actually start exercising, if we're using certain muscle groups predominantly, then those muscle groups start producing a lot more waste products. And then the body can kind of figure out, I had this big general response where I dilated all my skeletal muscle blood flow. And now this person's just going for a brisk walk. So I don't really need very much blood flow to my arms, but I need a lot more proportional blood flow to my legs. So we as we start moving into an activity, then we start being regulated less by this general sympathetic nervous system response and more by the conditions on the ground or in the tissues. Which tissues are doing the most work, producing the most waste? They're the ones that are going to create the stimulus to cause even more dilation to their area, so that we can make sure that we're flushing lots of fresh blood through that area to get rid of the waste and deliver the oxygen and glucose and things like that those muscles are going to need. So that intrinsic regulation is kind of twofold. We have the tissues themselves sending signals essentially that are telling the body, I can't keep working under these conditions. My pH is getting too low. I'm running out of things to make ATP with. I need some help with this, and I need more blood as a result. The other part of intrinsic regulation is that our blood vessels also can kind of self-regulate themselves. So when our blood vessels start sensing higher blood flows, they're going to dilate. They're like, there's a lot of blood flowing through here. It's a lot of pressure, so let's just go ahead and make it bigger. It's like if you have, like I know sometimes going up into some of the canyons for the ski resorts, they might have, and I don't know if they do it here because I don't really ski, but sometimes you'll have like 3 lanes of traffic. And in the morning, you might have 2 lanes going up to the resorts. And then in the afternoon, you have 2 lanes leaving to help traffic flow when it's dominantly in one direction or dominantly in the other direction. And so that's a way that the blood vessels can kind of regulate that too. If it senses a whole lot of flow, it's like, well, let's open another lane. Let's make that lane bigger so now we can accommodate that higher flow without driving the pressure up too high. So the intrinsic is kind of twofold. We have blood vessel intrinsic regulation as well as kind of tissue-driven physiological changes that are going to change how much blood is flowing through those different areas.
So on the subject of exercise, this subject really fascinates me. I've always heard that sustained aerobic exercise or training stimulates the growth of new blood vessels. Is that accurate?
Yes. Yeah, and it's mostly to help you maintain homeostasis in those tissues. So that if you are going to ask those tissues to do a lot of work and they're producing a lot of waste, the body's like, okay, if that's the case, I need to decrease the diffusion distances. So it's easier for me to deliver oxygen to those tissues and glucose to those tissues, and it's easier for me to pick up that waste. It's basically you're creating extra feeder streets, essentially, so that you're not just relying on the main highway, that you have a lot more kind of detours that are available to kind of help channel the blood where it's needed the most. So we will see that. And you will see it to a degree with resistance training, but aerobic exercise creates a bigger stimulus to increase blood flow just because it's much more continuous. Any activity that's more discontinuous, I'm going to do my set of bench press and I'm going to wait for 2 minutes. That waiting period while you're recovering lets your body kind of manage homeostasis a lot more easily than if you're continually producing waste for an hour straight. Then the body has to do a better job of clearing it out and increasing the what we call angiogenesis, creating more blood vessels in the tissue itself, make a huge difference with that.
So does that creation or that stimulation to create additional vessels happen at an aerobic level or an anaerobic level?
It'll happen both. At the aerobic level, it's driven more by the need for oxygen to kind of keep fueling the mitochondria so it can make lots and lots of ATP. When we do it at the anaerobic level, it's probably more of a waste removal stimulus, that all of a sudden we've produced all these hydrogen ions, our pH has dropped really low, and so we want to flush that waste stuff out. So it's probably, which is the bigger problem, the lack of stuff coming in that we need to do the job, or the need to get stuff out of the area to kind of get it back into balance so the enzymes and all that kind of stuff can work. So we will see it both ways, but it is kind of a different stimulus that's creating that drive. I like this slide. I'm not going to spend much time on it because just to have a lot to try and get through. But this is on the bottom of this slide, you're showing basically how much do these different organs in the body need blood at rest versus on the top, how much do they get during exercise. And so we've got it listed two different ways. You've got the percentages of blood flow from the total volume of blood being pumped. And then we also have just kind of the size of these little circles kind of is indicative too. And the size is more about the total volume rather than the percentage. So if we look at the total volume, heavy exercise, we might be pumping 25 liters of blood a minute. At rest, we're only looking at about 5 liters of blood a minute. The biggest difference during exercise is with skeletal muscle blood flow. 80 to 85% if you're working pretty vigorously. So you can compare the size of these two circles on either end of this top line, and you can see that, yeah, it's a huge big circle over here on the left, but most of it is taken up by the muscles themselves. All the other organ systems are definitely much smaller. A couple interesting things to note with the heart. We're getting a lot more blood flow volume-wise during exercise, but percentage-wise, it's still roughly about 5% of the total blood that we're pumping is going to the brain. Whether that's at rest, it's 5%. During exercise, it's 5%. It's obviously a much bigger volume during exercise because we're pumping 5 times as much blood in this example, but percentage-wise, we don't demand any more blood for the brain during activity than we do during rest. When we look at the brain, we see kind of an opposite dynamic. The brain basically doesn't matter if we're exercising or not. It really needs more of a set volume of blood. It's not a percentage. And again, the heart's muscles. So when we're trying to create more blood flow for the muscles, well, the heart's got to work a lot harder. And so that's why we see a bigger volume of blood for the heart during exercise than at rest. But when we look at the size of these two little circles for the brain, they're basically the same size. At rest, 15% of the blood flow is going to the brain. During exercise, it's more like 3 to 4% of the total volume. But again, if we multiply 3% times 5 times more blood flow, that's basically the same overall volume of blood that is getting pumped to the brain. The brain's not really having to work any harder to make us exercise than it does to just run every other aspect of our life to begin with. So we see very big differences between what happens with the heart. The heart kind of matches more along with what the skeletal muscle is doing because they are both working way harder. The brain's not really working any harder to make neurons that activate skeletal muscle fires than it is to make neurons that are just thinking about things fire. So big differences. Skin blood flow is going to be really variable depending on temperature. How much are you overheating and how much are you having to cool yourself off? That's going to be a big factor in how much of the blood needs to go to the skin. And when we look at exercising at a high intensity, if it's hot, we're not really going to cut blood flow to the heart. We're not really going to cut blood flow to the brain. What we're going to have to do is limit how much blood we can send to the muscles if we also have to send a significant amount to the skin to keep us cool. And so that's why it's so much harder to perform at a high intensity when it's hot. We just don't have as much muscle going to as much blood going to the muscles. We have to dedicate a significant amount to keeping us cool, to helping us radiate heat off of our skin and to help produce sweat. And then once we start producing sweat, we start losing blood volume, and then that makes our blood more viscous, harder to pump, and that can affect our effectiveness to deliver blood throughout the body as well, because we're losing volume. If I lose half a liter of sweat or a liter of sweat, that's a lot. I mean, that's, a fifth of our total blood volume, basically. So that definitely affects our ability to deliver lots of blood everywhere in the body. All right, let me skip through those. So we talked about cerebral circulation a little bit. Again, 15% at rest, and the volume is what is kind of more consistent. And according to this book, they're saying roughly 750 milliliters a minute, whether we're active, whether we're sleeping, whether we're running, we're always going to deliver about that much. The brain's got, the same number of neurons. Which parts of the brain are more active or not is going to vary. You know, if I'm doing a lot of physical exercise, then it's going to be more that precentral gyrus. But if I'm working more like on a crossword puzzle or trying to study, then it's going to be a lot more the anterior part of the frontal lobe where kind of our conscious thought, executive planning kind of takes place. If we're at like watching a movie where we have like lots that we're looking at the screen, lots that we're hearing, then we're going to see more interaction with those things associated with those sensory organs and those senses that we're getting stimulated. So it is going to vary quite a bit. Think about brain circulation kind of like cruise control in your car. And so if you look at this example here, the vessels in the brain are very delicate. We look at the capillaries and the smaller arterioles and things. And if we let too much force go through them, we can rupture them and cause many strokes. If we don't drive enough blood to the brain, then we get lightheaded and we pass out. So we have this very narrow window of blood flow that we need to keep it at. We don't want to get too high. We don't want to get too low. Both can cause really bad things to happen. And so I mentioned the cruise control, and I was just kind of thinking about it yesterday. Let's say you're driving downhill. You've got your cruise control set for whatever, 70, and you hit a stretch of highway, like you're going down to St. George and you're going out of Cedar City and getting ready to that really steep downhill part as you're coming down towards St. George. You don't need to touch the gas at all. Your car's going to be accelerating. And in that case, you're essentially like, if the brain is getting too high of blood pressure, we don't want the blood to cause rupturing of blood vessels up in the brain. So we want to throttle that back. So your car will essentially quit giving it gas and try to coast and try and slow things down a little bit more. When we have the other situation, if we're leaving St. George and trying to come back up towards Cedar City, your car is going to slow down because it's having to do a lot more work. And so that's like having a low blood pressure situation. We have to give it more gas to maintain that speed. So we need to push more blood to raise that pressure situation up. So we will see that mechanisms in the brain, and they're mostly in the baroreceptors, in the carotid arteries, as well as in the arch of the aorta, that help us understand what those pressures are, what those flows are, and is that going to be sufficient to drive blood to the brain or not? Is it going to overwhelm the brain? Do we need to throttle things back? Or is it too low? We're worried about that person passing out. We need to really increase the force of contraction and drive up that blood pressure a little bit more. All right, and then the skin. Again, if you're in a moderate climate and it's not that hot, you're exercising indoors in air conditioning in a neutral environment, you're going to send some blood to your skin to cool yourself off. That's nothing like you would do if you're trying to exercise in the middle of a summer afternoon outdoors when it's 95 degrees out and the sun's beaming down on you. And so we do have a lot of blood vessels in our subcutaneous skin so that we can bring it close to the surface of the body. If that blood is flowing close to the surface of our body, it's very easy for us to lose heat through a process called radiation, where the heat just dissipates off of our body. If we have the opposite situation where it's really, really cold out, most of us have experienced your fingers and your toes are usually the first things that you feel that cold in. It's basically because you're trying to divert blood to the core. We don't want to lose too much body heat and become hypothermic, and we're better off just keeping the vast majority of that blood around our critical internal organs. And if we lose a finger or two because of frostbite, oh well, at least we're still alive. And so that's kind of an extreme situation, but anytime you're kind of cold, then you're going to tend to shunt blood away from the skin so we can maintain overall body temperature. If it's a situation where we're really, really hot, then we're going to divert a lot more blood flow to the skin to help us both radiate heat off as well as to make sweat through the sweat glands and help evaporation. So those are, two of our primary ways of regulating temperature are either through evaporation or for losing heat, or through radiation, which is another way that we can kind of lose heat effectively through the skin. All right. I think we talked about pretty much everything on this slide already. So I'm going to keep cruising. And let's talk about our baroreceptor reflex. I'm pretty sure we went over this in anatomy, but we'll go ahead and talk about it again. And a lot of people have had this experience. You're lying down, and all of a sudden the doorbell rings. You're taking a nap on the couch. The phone rings, the doorbell rings, whatever, and you hop up to go get it. And all of a sudden you start feeling kind of woozy, and you're kind of lightheaded. Or maybe the first thing in the morning after you've been sleeping all night and your body's gotten really used to being flat and not having to fight gravity much, and all of a sudden you pop up. Blood's going to have a harder time going up to your brain because now gravity is pulling more blood down towards your feet. And so we get a very rapid drop in blood pressure at the level of the aorta and the carotid baroreceptors. If we are in an upright position, that blood is lingering down by our feet, then it makes our venous return less. And so the right atria and the right ventricle don't fill up as much. And when they don't fill up as much, then after that blood comes back from the lungs, then the left side doesn't fill up as much. And it's hard to keep a good high stroke volume. And if we can't keep the stroke volume up, then our pressure is going to drop unless we really do a lot of constriction to kind of compensate for that pressure drop. And so that's basically what the body's going to do is we get that drop in blood pressure. The baroreceptors sense that. They tell the cardiac centers in the medulla to do two things: tighten up those blood vessels so we can increase the pressure. And while you're at it, make the heart beat faster and stronger too, so we can drive up blood flow from that side of things. So if we can change the size of the system by shrinking the diameter of those vessels, and we can push more blood out, then we can still maintain adequate blood flow to the brain, and we won't have that person passing out or feeling really lightheaded. So that's kind of our baroreceptor reflex. It's again twofold. It's going to act through the cardiac centers in the medulla, cause vasoconstriction of arteries to increase that pressure, and then also drive the heart to beat faster and more forcefully to increase the total volume that we're pushing out. Both of those will raise blood pressure and help maintain adequate blood flow to the brain. If we're in the opposite situation, let's say decide I'm going to stand on my head for 30 minutes. Well, now we're not going to have any blood in the legs. It's going to be really hard to push blood all the way up to our legs because my legs are, up in the air. It's really easy for blood to get to my brain now because my brain's at the very bottom. And so in that kind of situation, you're going to see the opposite effect. You're going to have a really big stroke volume. And so then the baroreceptors are going to say, whoa, that pressure is way too high. We're going to just blow out a bunch of capillaries in the brain if we don't do something about that. And so in that situation, then we're going to do just the opposite. We're going to try to vasodilate more places in the lower body so that we can have more blood staying there and not overload what's going up to the brain quite as much. All right, how many people have taken blood pressures before? Couple. Okay, so we're going to go through this next semester. How exactly we're going to do it virtually, I'm not sure. We'll have to play around with that. We might have to look into getting you guys some kits that have blood pressure cuffs so you can practice those at home. I'll have to talk to Greg and Johnny about that because I have no idea what spring semester holds for us. But hopefully everybody's had their blood pressure taken. And so you get the cuff slapped on your upper arm. They pump it up. It's a bladder that they close off the valve on. So the pressure is just going to increase up to a point. And when that pressure gets high enough, it's going to create enough external force that it's going to occlude blood flow through that artery, through the brachial artery in your arm. And we open the valve and slowly start decreasing the pressure in the cuff. And as that pressure goes down, when it reaches the value that is our systolic blood pressure, it's basically matching the pressure in the cuff is matching the pressure in the artery when that wave of blood coming from the heart is getting pushed through it. And so that's when we will first start hearing noise. And you'll usually hear kind of a faint tapping sound initially. It's a limited amount of blood flow. We've decompressed the artery just enough to let like a trickle of blood flowing through there. And we're listening with the stethoscope and we're able to kind of amplify that sound. And we'll hear this faint tapping. And then as the pressure in the cuff continues to drop, a higher and higher volume of blood is now making it through that artery. It's not quite as compressed as it was. And that tapping sound will get louder up to a point, and then it'll start kind of fading away. and you won't hear it quite as distinctly. And as it starts fading away, what's happening is the pressure in the cuff basically becomes more equal to the pressure in the artery during the diastolic phase. So in between the beats, when we quit hearing blood pressure sounds is when we first quit hearing it, that's essentially the value that represents what the diastolic blood pressure is. So the first sound that you hear is your systolic pressure, and then the last sound that you could hear before it disappeared is your diastolic pressure. And once that pressure in the artery is equal to the pressure in the cuff, then basically we can't really, it doesn't create turbulence in blood flow, and we quit hearing the sound. So it really is basically trying to match what those forces are inside that vessel and help us determine that through an external way of measuring it. They have sensor where you can actually put a line into the artery and measure that arterial pressure directly. But that's pretty invasive and pretty risky, because then you got a needle in the artery, and if that pulls out, you got a pumper, and you're going to lose a lot of blood. It's not like a vein where it clots off really easily. So taking blood pressure from the outside is a great way for us to get a sense of how hard that heart is having to work to push that blood out and deliver it to the rest of the body. So those Korotkoff sounds are what we're listening for, and there's usually distinctly like 4 or 5. We'll talk about those more in therapeutic procedures 1 next semester. But the first Korotkoff sound is the first little faint tapping noise that you're going to hear, and then the last Korotkoff sound is the last noise that you hear before it disappears. All right, so we've talked about hypertension in pathology already, because we already went through all the cardiac stuff. And when this set of slides was put together was before they had actually changed the standard. So they used to say you want to be below 140/90 to be considered not high blood pressure. Now to be considered normal blood pressure, you need to be below 130/80. And really normal is 120 below 120 and below 80. And then when we get in between 120 and 130, then we're kind of like stage 1 hypertension, kind of pre-hypertension. And then we get above 130, now that's considered hypertension. It used to be 140. And you can be too high on either of these. Some people are too high on both of them. Most people that have hypertension, they're not really 100% sure why that person developed it. And so they call that primary or essential when we don't have a distinct causative effect. Secondary hypertension would be by some other known disease process. So let's say somebody has kidney failure and they can't make urine very effectively. They're going to tend to have too large of a blood volume, and that would cause them to have secondary hypertension, because essentially their pressure is going to be too high because their volume is too high because their kidneys don't work. If you have major atherosclerosis and you have major blockage of the vessels and they can't, they're plugged up, well, that's going to raise pressure too, but the cause was the atherosclerosis causing the hypertension. And there's definitely some carryover. Hypertension does cause damage to the blood vessels that contributes to atherosclerosis. So sometimes you can run into kind of a chicken and an egg situation. Did they have hypertension and that caused the heart disease? Did they have heart disease and that caused the hypertension? It's hard to know all the time which one was first. So hypertension does put more stress on your vessels. It puts more stress on your heart. It can cause more like mini strokes, tiny ruptures of capillaries in the brain that lead to loss of blood flow to certain neurons in the brain. And so it is considered to be the silent killer. Most people don't have a lot of true symptoms when they have high blood pressure. They feel fine. They slap that blood pressure cuff on and they're like, oh, 180/100. How's that like that? I don't feel bad at all. Sometimes people will get symptoms like headaches or ringing in the ear and things like that when their blood pressure is high, but the vast majority of people don't have any idea that they're high. They go in and get checked and they're high. So lots of treatment options. Certainly healthy lifestyle habits are going to play a role. And then I talked about the importance of decreasing sodium intake for those patients, especially the ones that are very salt sensitive. That can be a good measure. Sometimes taking in more potassium can kind of help with that. It just kind of helps Again, those are those two ions that help regulate so much in the body, sodium and potassium, and excess sodium tends to pull more water in, whereas the excess potassium doesn't have that same effect that the sodium does. And then we have lots of different medications. Fluid volume, that's going to be our diuretics like Lasix. Beta blockers are a really common thing to slow down the heart rate and force a contraction to try and lower blood pressure. We've got calcium channel blockers that those affect muscle contraction in the heart. So again, it's going to decrease the force of contraction. We talked about our ACE inhibitors already today, blocking the effect of switching angiotensin 1 to angiotensin 2. And if we block angiotensin 2 from being formed, then we're not going to release the aldosterone that also makes the kidneys want to hold on to both more salt and more water. So we do have a lot of options, but it can be really hard for physicians to get this in balance. A lot of times patients are on 3 different blood pressure medications, for example. One to make the heart beat less vigorously, one to help them pee out more fluid, another one to be an ACE inhibitor. It's really common to be on lots and lots of different ones when they're having a hard time controlling it. All right, then our last little bit on this slide is, or this set of slides, is about shock. And shock is kind of the opposite of high blood pressure. It's a low blood pressure situation. And we've got many different things that can cause shock. When somebody's, is bleeding too much, then they can go into shock. They're in a car wreck and they have internal injuries to their organ systems and things like that. And they're bleeding out inside, or they have, big laceration and they're bleeding out. They cut an artery. That's a situation where you could be very much hypovolemic. We can also see hypovolemia if we just get too much vasodilation. And so if we have more area for that blood to go in the body because all the vessels are wide open, then it becomes really hard to drive enough blood up to the brain because it's able to linger kind of in other spots of the body. And we'll see that sometimes. That's kind of more of a neurogenic shock. This middle point right here. So if somebody has a spinal cord injury and they've lost control of not only somatic nervous system in the periphery, but also the autonomic nervous system in the periphery, we can't send those messages to the vessels. The vessels are going to tend to dilate. Most of our blood vessels, when we stimulate them, they constrict because that's muscle contraction. And so if we can't activate those muscles and everything stays dilated, well, lots of blood can stay in the lower body and we have a hard time creating blood pressure in the brain. So those are a couple types of shock. Septic shock is an infectious process, usually an out of control bacteria that's gone from the local site in the body where the problem first was, and it's gotten into the bloodstream and it starts having systemic effects that cause low blood pressure. So sepsis is never a good diagnosis to see. We've talked about anaphylactic shock. Again, that is a vasodilation thing where our capillaries get very leaky and we get that fluid congestion in the tissues and the throat that can limit airway problems. But the other thing that's going on besides potential airway restriction is just lots of dilation everywhere in the body that's going to lower that pressure also. And then if our heart isn't capable of pumping, let's say I had a heart attack and a big chunk of my left ventricle is not generating any force when it contracts, then it's hard to make my blood pressure high enough to push blood everywhere in the body. My stroke volume is going to be really, really low with that situation. So almost all these different types of shock are going to be caused by a low blood pressure situation. And that low blood pressure situation can be for a number of different reasons. Too much vasodilation, not enough fluid in the system if we have a bleed out type situation, or an ineffective pump that can't drive enough blood through the system. So lots of different things that can cause problems with that. All right, we finally finished cardiovascular. So any last minute questions on that? All right, let's go ahead and take our break here. It's 9:10 on my clock there. So take about 10 minutes. When we come back, we'll go ahead and have our presenters ready to roll. So we make sure and get that knocked out. And then we'll get as far into the immune system chapter as we can once the presenters finish. So 9:10, take a break for 10 minutes, and then be ready to roll. All right, looks like our presenters are ready for action. So I'm gonna, or at least the slides are up. Maybe they're not personally ready. No, they're ready. They look confident. So I'm gonna let them go ahead and get us rolling here.
Okay, so our presentation is on the autonomic nervous system and how it affects athletes. So an overview of the nervous system, it has several branches and divisions that control the physiology of the human body. The first breakdown includes the central nervous system, which has the brain and the spinal cord in it, and then the peripheral nervous system, which includes any nerve that stems from the spinal cord or the brain. Within the peripheral nervous system, there are divisions called the somatic and autonomic nervous systems. The somatic nervous system controls all of our voluntary muscles and functions, and an example of this would be the movement of skeletal muscles. And the autonomic nervous system, which we're focusing on today, includes all of our involuntary muscles and functions, mainly managing our organs and their smooth muscles and glands. This autonomic system breaks down even further into the sympathetic and parasympathetic nervous systems. So if you want to switch slides for me, that would be great. Perfect. Okay. Autonomic nerves innervate the involuntary muscles. This includes cardiac muscle. Everything about the heart works on an involuntary level, the heart rate, blood pressure, and blood circulation. This also involves any smooth muscle. Smooth muscle is often found lining the visceral organs. Visceral organs are the ones found within the abdominal cavity, and they include all of our digestive organs. Autonomic nerves also control our sweat glands and any glands that secrete hormones such as epinephrine and norepinephrine. If you want to go to the next slide, perfect. There are two sets of autonomic neurons. The first originates in the brain or in the spinal cord, and it synapses on an autonomic ganglion, and the other one's cell body is found in the ganglion, and it synapses on the effector organ. Sympathetic nervous system is also called the thoracolumbar division. This is because the preganglionic fibers exit the spinal cord at T1 and L2. This division is responsible for our fight or flight response to stress. It mainly works with mass activation, meaning that when activated, it stimulates every tissue and gland that it controls. This is why your heart rate increases and you start breathing heavier, your pupils dilate, and your digestion stops all at the same time. And this helps your body prepare to confront whatever stress it's under or to run away from it. The parasympathetic division is also called the craniosacral division. This is because the ganglions originate in the midbrain and S2 through S4. The system controls the rest and digest functions in our body. It controls the bodily functions while we sleep, such as the enzymes that help digest our food and activating our metabolism. The preganglionic neurons of the PNS neurons, and the PNS uses cranial nerves to communicate with the rest of the body. So the long vagus nerve carries the most parasympathetic fibers, which go to the muscles and organs in the upper half of the abdomen. This includes the lungs, heart, esophagus, stomach, the pancreas, small intestine, and the upper half of the large intestine. And the preganglionic fibers from S2 to S4 innervate the lower half of the abdomen and the lower half of the large intestine, rectum, urinary, and reproductive systems. Okay, dual innervation. Sorry, will you go back to that one slide? Thank you. So there are some parts of the body that is innervated by both the sympathetic and parasympathetic system. This is known as dual innervation. There are two types of dual innervation, and the first is when the systems complement each other, so they produce a similar effect. A really good example of this is the salivary glands. The parasympathetic system produces a watery saliva, while the sympathetic system constricts the blood vessels so that the secretion of the saliva is thicker. And the other kind of dual innervation is known to be more of a cooperative process. The systems are producing different things that lead to the same action. So one example is urination. The parasympathetic system contracts the bladder, and the sympathetic system controls the internal urethral sphincter that allows the urine to pass through.
Okay. So now we're going to be focusing on how it affects athletes, and more specifically Olympic athletes. So which part? It's going to be the sympathetic system that is going to kick in, the fight or flight or stress. So neurons from the SNS generate and prepare the body to react for something in its environment. So this is, I know she went over some of it, but this is just a breakdown that I really liked, kind of an analogy. So the sympathetic nervous system functions like the gas pedal in a car. It triggers the fight or flight response, providing the body with a burst of energy so it can respond to the perceived danger in the environment. So how the body responds, what goes on in the body, the heart's going to start beating faster, pushing more blood to the muscles that are being used. The blood rate and blood pressure increases, small airways in the lungs widen, extra oxygen is sent to the blood to increase awareness, pupils dilate, sight and hearing become sharper, triggers to release in temporary glucose storage to supply more energy to the body. So how it's going to benefit for competing. So the increase in intention is going to happen, able to get more air and oxygen in throughout the body, increase blood flow to the major group muscles that they're going to be using. I believe that this one can be both a good and a bad thing, depending on how you look at it, but can block pain. Of course, it can hurt something, but when you're thinking about just competing, I guess it can be thought of as a benefit. And then prevent dialogue of self-doubt while you're competing. Can it be a bad thing if adrenaline reaches a certain limit, the performer becomes overstimulated? So this is where in competitions or games, races, you're going to be seeing the athlete freeze or easy mistakes early on in the game or competition. How we can get the nerves to work with you and not against you. The number one thing that they brought up was pre-game rituals. They believe that this helps because there's a lot of choices that go on before games and uncertainty. But if you know simple things like what you're going to be eating the day before the game, snacks before the game, it could be as silly as like what kind of socks you're going to be wearing, but it's less choices for the athlete to choose before the game. Listening to music, just kind of getting in the focus and the mindset of the game. Practicing visualization, so thinking about how you want the game or race to go in your mind, and then banish all negative self-talk before the game, so only thinking positive about how you're going to perform or actions that you want to do. And this is a video, so this is a a professional snowboarder, I believe, and he goes through kind of his mindset before the game and how he thinks and things that he goes through, things that he notices on the many times that he competes. And let me know if you cannot hear it. I think I made it where you guys can.
I'll visualize a run the way that I want to see it done. I usually kind of do this like off to the side, away from everybody, sort of in my own quiet space. When you're in the gate and you're standing there getting ready to drop, it is the most present, hyper-focused moment of my entire life. I've just sort of buckled my snowboard on. I can feel the pressure of my straps on my ankles. Is it snowing or is it sunny? Is there wind on my face? I reach over to the gate. I make sure the handles are adjusted to the right height. I'm looking at the top of the start gate, just waiting for it to move, trying to feel what that adrenaline's like. The gate opens. I can hear it. It makes like an audible click. I imagine like the exhale of my breath, because you're holding your breath. And when you pull, you're pulling as hard as you can and trying to generate as much speed. And so it's like this exhale and react. I have to move really quickly over the first two features. It's real target shooting. You really have to like barely pick your feet up and over. I can hear the wind going through my goggles, and I can sort of feel it on my eyes, going probably 40 miles an hour through there. I'm jockeying for position, making sure that my body position's really good. I know people are going to be trying to crowd my space. If you're driving a car and you have a 5-lane road and 6 cars and you're all trying to fight to go the fastest, you're going to hit each other. You're going to bump against each other. You're going to trade pain. Rubbing is racing, being close to each other. That's the chaos. Like if you slip up in the first corner, your day could be done. It's like first round, first run. I always imagine taking a pretty big, deep breath. You're about halfway through the course. A lot of times you can hear like an edge running through the snow or somebody coming up short on a jump. My heart rate's going through my roof. If there's a competitor in front of me, I'm staying right on their tail and braking off to the left just at the last second before I go through the last 2 rollers and across the finish line. Even when I'm just visualizing it right now, when I cross the finish line, it's this like huge relief. It's like, okay, I made it down safe. I'm going on to the next round. Like, let's do this again. I'm not out there knitting sweaters, you know, like I'm racing border cross because it makes me feel alive and because I love it. It's gnarly. God damn, it's probably, but yeah, it's the best drug you can be able to do, so it's good.
There we go. So I really like some of the ideas that he went through that even though you may not snowboard, he really took through like the whole race, how he feels from beginning to end, from things that he notices. I really like the specific details that he brought up of like being able to feel and like strapping into a snowboard and feeling like being able to hear his edge or someone coming up behind him, just all the specific details that he remembers in his race every single time he does. And I really thought it brought really good insight of a professional athlete competing. Any questions?
All right, thank you, ladies. You know, sports psychology, which is basically what the guy was talking through, the visualization part of things, can be hugely helpful. I mean, there's been plenty of studies looking at how effective it is, and it's different for different types of sports, how the techniques that you might use, and certainly ones where you know what's coming up, where you're more in control of things. You have a lot more different options. So like a golfer is totally in charge of their shot. So it's a lot easier for them to visualize how they want their swing to be, how they want the flight of the ball to go, all those type of things. Athletes like snowboarders or bobsledders, when they know the specific course and have practiced it enough, then they can visually see themselves going through the specific moguls, the specific turns, and the more realistic you can make your visualization, the more effective it tends to be in helping your performance. When you're in sports that are more dependent on playing an opponent directly, it's harder to predict how those things are going to come forth because you don't know what that player is going to do. So it's harder to do visualization with, most of your ball and field type sports because things are a little bit more chaotic and not always entirely predictable. But for those activities where you do know what to expect, then you can definitely use a lot of things like imagery and visualization to really help with that. I think just in general, the ability to kind of be in control of your mind and to calm yourself down even when you are very anxious is another big part of it too. And when you are feeling too anxious and you can't get control of those emotions, then it is harder to have good mental clarity. And probably some of you maybe have experienced that during practicals the last time. You get nervous and you start recognizing that you're nervous, and then it's that much harder to kind of regain your focus and get back to where you were. So those, these visualizations and relaxation techniques and positive self-talk and things like that are things that can definitely help work performance, school performance, athletic performance, even just like interpersonal interactions. If you have like a tricky topic to discuss with a spouse, with a family member, something like that, and you're likely to get worked up about it, then the more you can practice kind of how that conversation might go, try and visualize what their response is. All those things can help you be better prepared to keep your cool and respond more appropriately and more effectively in those kind of crisis situations, whether it's a crisis that we're kind of building up in here, or whether it is a true like life or death type crisis that you might see in wartime or sports or something along those lines. So lots of application and definitely can have a really positive effect in using helping you make better use of the hormonal changes that help us to perform without becoming too amped up and too anxious and too nervous that you're going to make mistakes. And that's where being able to keep control of things can make a big difference. All right. Let me share my screen so we can keep rolling on the immune system, or get rolling, I should say, on the immune system, since I haven't started it yet. So we're going to go kind of heavy on my friend Hank today. He's got 3 different clips on this topic. We'll probably get through the first 2 of them, but I feel like he does a great job of going through all the basics, and then we'll be able to kind of scroll through the content in the PowerPoint slides a little bit quicker after kind of hearing from him on some of these key topics. So let's start out with this one. Provo College Nursing Program. We're going to skip that ad.
You may not know it, but your body is engaged in a never-ending battle. You are literally covered in staph and strep and E. coli and all sorts of dubious characters that are intent on using you and your body's many resources to feed themselves, find shelter, and reproduce as much as they want. And hey, we all gotta make a living, but it is not your job to give these guys a free lunch. So your body has developed a 3-part policy toward these shady customers, and its enforcement is handled by your immune system. The immune system is different from all the other systems we've talked about this year in that it's not a specific tissue, organ, system kind of system. Instead, it involves a whole bunch of different tissue groups, organ systems, and specialized but widely distributed defense cells. Together, this league of extraordinary substances joins forces to perform all of the defense functions your body depends on to keep you alive in an incredibly germy world. And the first line of defense in this never-ending battle, that's your innate or non-specific defense system. Like your average frontline soldier, it's prepared to immediately engage with anyone suspicious, and it mostly includes stuff we were born with, like the external barricades of your skin and mucous membranes, and internal defenses like phagocytes, antimicrobial proteins, and other attack cells. But some enemies must be fought with special forces, and here your body can deploy your adaptive or specific defense system, which is more like your SEAL Team 6. It takes more time to call in, but it's specially designed to go after specific targets, and it keeps files on those bad guys so it knows how to handle them next time around. But today we're going to focus on your innate system and look at how it uses an arsenal of physical and chemical barriers, killer cells, and even fever to keep you healthy, proving that sometimes the symptoms we associate with illness are actually the signs that we're healing. Just because something is simple doesn't mean that it can't be elegant. I mean, your body is capable of some incredibly sophisticated things, including defending itself from infection. But occasionally, there's something to be said for brute force. And a lot of your innate immune system's functions aren't exactly subtle. For example, your body's very first line of defense is a simple physical barrier. And it works. Like a wall around a fortress, your skin does a fantastic job of keeping out all manner of malevolent microorganisms. As long as that tough, keratinized epithelial membrane doesn't get torn open or busted up too much, you could probably, like, make snowballs out of raw sewage and still be alright. Although, no. Your many mucous membranes also provide a handy physical barrier. You'll remember that they line any cavity that opens up into the germy outside world, including the respiratory, digestive, urinary, and reproductive tracts. Not only do your skin and mucosa supply simple physical protection, they also pack some serious chemical weaponry. Eat some questionable leftovers for lunch? Don't worry, your stomach is literally filled with acid, so you probably are covered. Walk face first into your coworker's nasty sneeze cloud? No worries, your nasal passages can whip up a tissue box worth of sticky mucus to help trap viruses before they enter your lungs. You've also got bacteria-fighting enzymes in your saliva and lacrimal eye fluid, and peptides called defensins in your skin and membranes that help keep bacteria and fungi from setting up shop around inflamed or scraped skin. Which, no matter how careful you are, you're gonna get one way or another. Maybe you shave with a dull blade, or you just brush your teeth too hard, and don't get me started about the dangers of bagel cutting. So when you've breached that first simple line of defense, it's time to call on your second line of internal innate defenses. This is where your body starts pulling strategic maneuvers like firing up a fever, releasing chemical signals, causing inflammation, or other defensive tactics that help identify and attack infectious invaders. Some of the first defensive cells on the scene are your phagocytes. Their name literally means to eat, and like Pac-Man, they indiscriminately chase down intruders and gobble them up. And they come in a few different varieties. First, you got neutrophils, which are the most abundant type of your white blood cells. They kind of self-destruct after devouring a pathogen, and in fact, you've probably seen piles of their little dead bodies, because that's what pus is made of. But the bigger, tougher phagocytes are the macrophages. They're derived from monocyte white blood cells that have moved out of the bloodstream to occupy tissues, and some are free types that patrol tissues looking for creepers, while others are fixed, attached to fibers in specific organs, devouring anything suspicious that passes by. So when a macrophage, in say the finger I just cut slicing a bagel, sees a new bacterium coming along, it snares it using cytoplasmic extensions, reels it in, completely engulfs it, and essentially digests it and spits the rest out. And unlike neutrophils, it can do this over and over again, like a boss. But not all your defense cells are phagocytic. You've also got cells with what is by far the awesomest name of any cell in the body, the natural killer cells. You can call them NK cells if you want to, but like, why would you do that? Anyway, these tiny assassins patrol your blood and lymph looking for abnormal cells, and are unique in that they can kill your own cells if they are infected with viruses or have become cancerous. How can they tell? A normal, healthy human cell contains a special protein on its surface called MHC1, or Major Histocompatibility Complex, but if it's infected, it stops making that protein. And if an NK cell detects a defective cell, it doesn't swallow it whole like a macrophage, it pokes it with an enzyme that triggers apoptosis, or programmed cell death. Which is pretty awesome. So those are some ways your innate immune cells handle their enemies, but how do they know where to look in the first place? So let's talk strategery. So say you're in a banana factory, and you slip on a banana peel and you scraped your knees. Your outer fortress has been breached and the pathogens are just flooding in like orcs through Helm's Deep. Banana factories are very dirty places. Now your body wants to contain the spread of pathogens, clean up the mess, and get healing as quickly as possible, so it cues up your inflammatory response. This is basically an internal fire alarm, only it uses chemicals instead of sirens to get the message across, and instead of smoke and fire, you sense redness, swelling, heat, and pain. For example, in the event of injury, specialized mast cells in your connective tissue send out histamine molecules, and histamine is great at calling in the cavalry. For one thing, it causes vasodilation, which creates redness and heat at the site of the injury. Now, those things might freak you out a little, but they're actually signs of healing. The increased temperature, for example, ratchets up the cell's metabolic rate so they can repair themselves faster. Meanwhile, histamines and other inflammatory chemicals also increase the permeability of of blood vessels, causing nearby capillaries to release protein-rich fluids. This causes swelling, which again is actually a good thing because that leaked protein helps clot blood and form scabs, while the lymphatic system sucks up and filters that extra fluid, cleaning it up before putting it back into your bloodstream. And of course, like chum to sharks, an inflamed knee is also going to attract a bunch of local phagocytes, which find it easier to escape your now leaky capillaries, and lymphocytes that are also flowing freely, helping to destroy pathogens while also cleaning up dead cell wreckage. And don't forget, during all of this, the neutrophils have been doing their best, but they were the first wave to arrive, so by this time they're starting to die in heaps. They're triggered when the injured knee skin cells release chemicals that begin leukocytosis, the release of neutrophils from the bone marrow, where they're made, into the bloodstream. To attract the neutrophils to the damaged area, inflamed endothelial cells in the capillaries send out chemicals that act like homing devices. And when the neutrophils arrive, they cling to the capillary walls near the injury, flatten themselves out, and squeeze through the vessel walls to get to work. Your big monocytes eventually roll up to the battle and transform into hungry macrophages, replacing the first line of now dead neutrophils and basically just eating up any lingering enemies and then cleaning up the carnage. Now, all this works pretty well in most circumstances, but you may have noticed with a more major injury or an especially nasty virus or infection, sometimes your local troops get overrun. When white blood cells and macrophages run into more foreign invaders than they can handle, they let loose pyrogen chemicals that tap the hypothalamus and raise your body's thermostat, calling in a systemic fever to burn everything. The resulting temperature rise increases the metabolism of your cells so they can heal faster, and it also tells the liver and spleen to hold on to all of their iron and zinc so those things can't contribute to bacterial growth. But even then, sometimes you find yourself facing a more formidable foe. That's when you call in the specialists, your adaptive immune defenses. And to learn exactly how they save the day, you have to watch next time. But for now, you learn that your immune system's responses begin with physical barriers like skin and mucus.
Craig, you're muted.
So Hank's kind of got his gamer vibe going with that set of videos there. The little neutrophils and macrophages are such little cute guys too, until they start eating everything up. So nice little synopsis of all the different components in our innate system. And again, our innate is what we're born with. And these are just the way our body is put together and the way that our body can prevent infection or trauma or damage from just garden variety, any kind of organism that might come into play. And again, depending on what type it is, we'll have different things that block different actions of these invading organisms. So we've got all this stuff externally that he kind of mentioned. Our skin does a great job when it's intact. When we get, damage to it, then we open up avenues for infection. And so our post-operative patients in particular, or patients that have suffered burns or other type of trauma like that, are going to have a much higher risk of infection than somebody whose body is just intact and we're just dealing with a tendonitis type of situation, for example. GI tract, respiratory tract, urinary system tract, all those, basically those mucosal membranes all have things related to their just inherent properties that serve as protection to us. And then when we get inside the body, then those are kind of all the different cellular components that he was just talking about, the neutrophils, the macrophages, the NK cells, and the mast cells, and the inflammatory response, which we talked about a lot at the beginning of pathology, just understanding what happens with inflammation. So our white blood cells are going to migrate and leave the capillaries. They're small enough and they're flexible enough that they can kind of squeeze out the really small gaps between adjacent cells. And again, if we are in an inflammatory situation where we're causing increased capillary permeability, it gives these white blood cells an even easier time out of those vessels so that they can get into the interstitial space where the invading organism is kind of trying to take up residence and multiply and grow and destroy tissues. The adaptive immune system's a little different. That's kind of what we're all waiting for with the coronavirus vaccine, is basically a synthetic adaptive immunity that we're trying to get. And certainly people that have already had coronavirus will have generated their own internal adaptive immune response. And so that's kind of what this next set of information is about. So we're going to watch Hank on that one too. and then be able to scroll through that content, hopefully fairly quickly.
What's true in World of Warcraft is also true in your immune system. To defeat your enemy, you have to know your enemy, uncover its weaknesses, learn how to see it before it sees you. We've already talked about how your innate defense system keeps out or quietly neutralizes pathogens without too much fuss. But sooner or later, a threat's gonna come along that's stronger than what the first responders can handle. That's when it's time for the adaptive or acquired immune system to step in. While your innate system takes its zero tolerance policy very seriously and tries to toast any foreign microbe that it encounters, your adaptive system does things differently. It has to be expressly introduced to a specific pathogen and recognize it as a threat before it will attack. As its name suggests, you're not born with a working adaptive immune system. It's slow to act, in part because it takes time for it to shake hands with so many pathogens and get to know them. These introductions may be organic, like touching a dirty faucet in the bathroom or walking into a sneeze cloud, or they may be premeditated, which is why vaccination is pretty much the greatest thing to happen to medicine ever. But once it's been introduced to a potential threat, your adaptive defenses never forget it. And this ability to remember specific pathogens is one of the key differences between the adaptive and innate defenses. Another main difference is that adaptive immunity is systemic. Rather than being restricted to a particular infection in, say, a sinus or a sliced finger, your adaptive system can fight throughout your whole body at once. And it does this by deploying one or both of its separate but cooperating defenses, your humoral immunity and your cellular defenses. Your humoral immunity, which you might not have heard of before, works by dispatching important proteins that I'm sure you have heard of, antibodies. They're made by special white blood cells, and they patrol the body's humors, or fluids like blood and lymph, where they combat viruses and bacteria moving around the interstitial space between your cells. Much of what you know or have heard about or think of when your immune system comes up actually has to do with your humoral immunity. It's why if you had mumps as a kid, you probably don't have to worry about getting it again for the rest of your life. It's also why doctors and nurses and patients who have been infected with the Ebola virus, a disease once thought to be incurable, have lived to tell about it. And it's why vaccinations work. Whether you're protecting yourself from infections or playing an MMO, one of the first steps in any good defensive strategy is to be able to tell your friend from your foe. And in the case of your immune system, that means being able to identify antigens. An antigen could be an invader from the outside world, like a bacterium, virus, or fungus, or it could be a toxin or a diseased cell within your own body. But in any case, antigens are large signaling molecules not normally found in the body, and they act as flags that get the adaptive immune system riled up. So let's say flu virus gets inside of you, and it's floating around trying to find a good host cell to start multiplying inside of. Before it finds that cell, hopefully it will be paid a visit by one of the stars of your humoral response, a B lymphocyte. Like all blood cells, these guys originate in your bone marrow, but unlike other white blood cells, they also mature in the bone marrow too. And as a B cell matures, it develops the ability to determine friend from foe, developing both immunocompetence, or how to recognize and bind to a particular antigen, as well as self-tolerance, or knowing how to not attack your body's own cells. Once it's fully mature, a B lymphocyte displays at least 10,000 special protein receptors on its surface. These are its membrane-bound antibodies. All B lymphocytes have them, but the cool thing is every individual lymphocyte has its own unique antibodies, each of which is ready to identify and bind to a particular kind of antigen. That means that with all of your B lymphocytes together, it's like having 2 billion keys on your immune system's keychain, each of which can only open one door. So part of your immune system's strategy is just to win with overwhelming odds. The more unique antibodies your lymphocytes have, the more likely it is that one will eventually find, bind to, and mark a particular antigen. Once they've matured, B cells colonize or seed your secondary lymphoid organs like your lymph nodes and start roaming around in your blood and lymph. At this point, they're still naive and untested, and they won't be truly activated until they meet their perfect enemy match. Which brings us back to the flu virus. When the right B cell finally bumps into an antigen it has antibodies for, usually in a lymph node or in the spleen, and recognizes it, it binds to it. This summons the full power of the humoral immune response, and the cell basically goes into berserker mode. Once activated, the B cell starts cloning itself like crazy, quickly producing an army of similar cells, all with the instructions for the exact same antibodies that are designed to fight that one particular antigen. Most of these clones become active fighters, or effector cells, but a few become long-lived memory cells that preserve the genetic code for that specific successful antibody. This ensures that if and when the antigen returns, there will be a prepared secondary immune response that's both stronger and faster than the first. This is key to why vaccinations are so brilliant and important, which I'll come back to in a minute. But while the memory cells are just there to hang back and record things, the effector, or plasma cells, are packed with extra amounts of rough endoplasmic reticulum, which acts as an antibody factory. These cells can mass produce the same antibodies over and over for that particular invader, spitting them out into the humor at a rate of around 2,000 antibodies per second for 4 or 5 days until they die. And the antibodies they make work the same way that the membrane-bound ones do. They're just free-floating. So they ride the tides of blood and lymph, binding to all the antigens they can find and marking them for death. Now, antibodies can't really do the killing themselves, but they do have a few moves that could make it hard for intruders to take hold. One of their most effective and common strategies is neutralization, where antibodies physically block the binding sites on viruses or bacterial toxins so they can't hook up to your tissues. And because antibodies have more than one binding site, they can bind to multiple antigens at the same time in a process called agglutination. The resulting clumps can't get around easily, which makes it easier for macrophages to come and gobble them up. And not only that, but while all this is going on, antibodies are also ringing a chemical dinner bell, calling in phagocytes from the innate immune system and special lymphocytes from the adaptive system to destroy these messy little antigen-antibody clumps. So the point of all of this in the short term is to keep you healthy, but in the long term, this process also adds to your overall immunity. The humoral response allows your body to achieve immunity by encountering pathogens either randomly or on purpose. Active humoral immunity is what we were just talking about. It's when B cells bump into antigens and start cranking out antibodies. This can occur naturally, like when you catch the flu or get chickenpox or pick up some nasty bacterial infection, or it can happen artificially, particularly through vaccination. Most vaccines are made of a dead or extremely weakened pathogen, and they work on the premise that because a secondary immune response is more intense than a primary response, by introducing a pathogen into your body, you're priming it to fight hard and fast should that antigen show up again. In the case of typically non-fatal infections like the common flu, this immunity should at least spare you from some of the most severe symptoms. But in the case of more serious diseases like polio, smallpox, measles, and whooping cough, vaccinations can be truly life-saving. Now, some antigens, like those for mumps or measles, don't really change much over time, so a few immunizations will leave you set for life. But others, like influenza, are constantly evolving and changing their surface antigens, so immunity to last year's flu probably doesn't work against this year's flu. Still, acquired immunity doesn't have to be active. Babies, for example, naturally obtain passive humoral immunity while still in the womb. They receive ready-made antibodies from their mothers through the placenta and later on through breast milk. And that works pretty well for a few months, but the protection is temporary because passively obtained antibodies don't live long in their new body, and they can't produce effector cells or memory cells, so a baby's own system won't remember an antigen if it gets infected again. You can also acquire this kind of temporary passive immunity artificially by receiving exogenous antibodies from the plasma of an immune donor. This is what recently saved some doctors and nurses who had contracted the Ebola virus from infected patients. A serum was made from the blood plasma of other medical workers who had been infected and survived. The antibodies helped defend the patients from the virus before their own active immunity could identify that particular antigen and start creating their own antibodies. It's not the same as a vaccine, which immediately engages your B cells, but it can buy a patient some crucial, life-saving time against an infection that would otherwise quickly kill. But B cells and antibodies are only part of the immunity equation. There are plenty of pathogens that quickly worm their way right inside your cells, where they're safer from the humoral response and free to multiply as much as they'd like. Luckily, your immune system has yet another game plan and a new set of players ready to fight that final battle with cell-to-cell combat. Make sure you catch our final episode next week and learn all about this epic battle royale. But as for today, in our second to last episode, you learned how the adaptive immune
We may not get to the battle royale today, but we'll see if we can get close to it. I know you're waiting with bated breath, very anxious. Your sympathetic nervous system is probably like just through the roof right now with the intensity of these invaders attacking us.
So going back to that first segment, and I think we've had this conversation before. According to that, taking anti-inflammatories and fever-reducing drugs is counterproductive.
Yes. they make you feel better at the time you're taking them, but as far as helping your body deal with whatever it's dealing with, they're blunting our immune system response. But they do decrease
Literally
symptoms.
slowing the healing process.
Yes, potentially. Yeah. Yep. So there's trade-offs. I mean, too much swelling can be problematic and can be hard to get rid of. So when you take things to limit swelling and you do RICE and follow that acronym, it helps some parts of the response and impairs some parts of the response. So I think it's kind of situational and can vary depending on your philosophy and your body's own kind of way that it responds. Do you create a big over-exaggerated immune response, or do you have a more subtle kind of less vigorous response? But yeah, overall, I mean, I think more people believe that now, that we should just let things run its own course to a degree. And I think, I agree with elevating and compressing more so than like taking Advil to help with it, because I think that's going to change things chemically, whereas elevating and compressing, you're changing more the physics of things by making it harder for edema to develop, but you're not necessarily preventing the biological processes from falling through chemically with what they feel like they need to do to help correct things. All right, so that video that we just watched has tons of relevance for the coronavirus, and they've talked about people that have been exposed, that recovered, how they're taking their plasma and trying to create concentrated doses of the antibodies that they can then inject into people that are sick. And that's kind of like how a tetanus shot works. That's also how, like, if somebody gets a snake bite, rattlesnake bite, and they're going to give them antivenom. That's essentially the antibodies that are designed to fight off that venom. And it's created by somebody that did get bit previously and created those antibodies in the first place. And so something like a tetanus shot, you get a puncture wound with a rusty nail or whatever, you can get the shot and it's going to actually deliver those antibodies to you right then and not wait for your body to kind of ramp up and make its own. So there are some things like that that can be given after the fact, but most of the time we're giving vaccinations preemptively so that if we do later get exposed to something, we're going to have the ability to fight that off. And that's kind of more the idea behind the flu shot every year, which you mentioned, kind of how it morphs and how that works for, measles, mumps, rubella vaccinations, shingles vaccine, all those type of things you do ahead of time. And it is based on, we have to have, the body has to recognize the invading antigen so that it can create the appropriate antibody. And so when we take vaccines, we're basically trying to introduce that antigen in a safe way so the body is now better prepared if we do happen to come in contact with that organism later on. So our lymphocytes, that just means, and those are just different types of white blood cells. And we've got two primary types. We've got our B cells and our T cells. So B lymphocytes and T lymphocytes. T lymphocytes originally start in the thymus, and then the thymus gland kind of dissipates as we get older. And at that point, the stem cells that were making those T lymphocytes have usually taken up residence in the bone marrow or in the tonsils or in some of the other lymphoid organs, so they can continue to make those T cells. The B cells are kind of always were in the bone marrow to begin with, and so they're going to be generated there when we need to make more of those. And we've got different subtypes of both the Bs and the Ts. So we'll kind of talk about those a little bit. So our Ts they don't make any antibodies. Only the Bs make antibodies. But the Ts are good at fighting most of our viruses that we get exposed to, funguses, cancer cells, things like that. The B cells tend to be a little bit more geared towards fighting off bacteria, and they're the ones that are going to make just lots and lots of antibodies. The B cells are usually just about marking the invading organism or generating lots of antibodies that can then be free floating and potentially attached to invading organisms, but they don't do any of the killing themselves. The T cells, some of the T cells are more about marking invading cells, and other T cells actually have the ability to kill them and take them out of commission. So the T cells are a little bit more versatile, and they do have a little bit more firepower. The B cells are more like they can make a citizen's arrest, they can put somebody in handcuffs and kind of restrain them and slow them down, but they can't really take them out. So the T cells are a little bit better fighters in that respect. So again, B cells mostly about bacteria. They do help with some of the viruses as well, but they're not going to be very effective against like cancer cells and things like that. All right, so I talked about the thymus already. Our secondary lymphoid organs, the spleen, is basically going to be checking the blood for invading organisms. Our lymph nodes are basically small nodules essentially in the lymphatic system itself. So they're screening the lymph for invading organisms, and the spleen is screening the blood for invading organisms. Our Peyer's patches are tied into our small intestine. And so if we've consumed something that's potentially harmful and it survives through the stomach digestive process and gets into the enzyme, and we absorb that into the bloodstream through the walls of the intestine, then the Peyer's patches are kind of screening that stuff coming through to try and find invading organisms too. So pretty much any place where things can come into the body, we have specialized organ systems that are going to try to screen the things coming in. Think like the TSA screeners at the airport. Before you can get onto the plane and go to the gate, you've got to go through that checkpoint. And that's what most of these secondary lymphoid organs kind of function as, some sort of checkpoint where we can screen those fluids a little bit better. The local inflammatory process you kind of talked about in the first video. Basically, if we have that scrape, we're going to have the neutrophils come in first. They're short-lived. They create the pus that you are probably familiar with. Most people have had some sort of pus associated with an infection. The macrophages then come in to help, and then we have all the vasodilation and swelling and all those other things that take place, the prostaglandins and the kinins and all these things that come in. One of the other components that we see, and usually we'll see this also with when B cells become activated and are trying to fight off an infection, is what's called our complement protein system. And so our complement system is part of the innate, or that we're born with, part of the immune system. So we'll come back to those. And the complement system are basically the cells that can actually help kill off the things that the B cells have identified as being a bad cell that we don't want. The B cells, like I said, they can mark it, but they can't really kill it. The complement proteins can kind of help the B cells to take those things out of commission. We'll look at that in a sec. So here's an example of a pathogen that looks like a hot dog bun. And the antigens on it look like little Monopoly houses or something. The antibodies are essentially the green part. So we've got our B cells with this antibody that's attached to it. And once an antibody on the B cell attaches to an antigen on a foreign cell, then it recognizes that that thing's supposed to not be here. And that's what's going to cause what they call that opsonization, where that B cell now is going to generate lots of antibodies that are just going to be spewed off of the B cell itself. And now all those antibodies can be free floating in the bloodstream, in the lymphatic system, to help find more of these invading cells. Because if you found one, they never come alone. You're pretty much, it's probably already divided multiple times. So if you have one bad cell, bacteria, virus, fungi, or whatever, you're probably going to have thousands more. And so we want to be able to find all those things. So we need to have this widespread response that's just basically going to let these antibodies circulate throughout our bloodstream to try and identify all these other invading organisms.
I have a question real quick.
Yep.
So my sister, she just developed a cold, and she's like, I drank 1 gallon of water to flush it out. Is that like a true, does water like flush things out faster?
I mean, it's going to dilute the concentration of anything for a short period of time. Our kidneys will tend to correct that pretty quickly. If you're dehydrated, then it can help. And certainly our cells do better if they have their proper amount of water. But I don't know that it's necessarily going to wash those things out of your body. You have to have some other mechanisms to do that. You might lose a few, but you really need to get the immune system responses ramped up to be truly effective. You're still going to be harboring those things. I don't know that it would. I'm not saying it's worthless to drink a lot of water. We definitely always want to stay hydrated when our body is having to fight something off. So it's better to be well hydrated than not, but I don't know that it truly physically is going to flush them out of our body more effectively. All right, so our antibody response, when our B cells recognize an antigen and bind to it, it will do, it's multifold. So we'll start doing cell division. So we'll go through mitosis and make more B cells. And then of those new B cells that are created, some of them are going to be just like the first B cell that came in contact with that antigen, and they're going to have the ability to generate antibodies that they can then release. So those are called plasma cells. I think he called them something else, target cells or something else. I can't remember what phrase he used, but the plasma cells are the ones that are going to have the really extensive machinery to make lots of antibodies. And then the memory cells are the ones that really help give us that protection when we get a vaccine. They're the ones that are going to linger in the body for a longer period of time. They're not necessarily great at making lots of antibodies, but they're great at sticking around for a long time, so that if we get that bug 2 years from now, we still have memory cells that go, oh yeah, I remember that guy from 2 years ago. We didn't like him very much. He caused a bad response the first time we got exposed to him. So now let's take him out, and we're ready to do that. So the memory cells are what give us that response that we're after with vaccine, the immunization that's long term. The plasma cells are the ones that are going to be immediately effective in trying to negate that infectious organism right now, not necessarily in the future. So we'll make both of those through cell division. And then our B cells, in addition to making more antibodies, also activate those complement proteins that I talked about. And most of those complement proteins will usually cause some sort of hole in the wall of the bacteria, of the virus, of the fungus, that makes it basically lose its fluid. And so if we poke a hole in the wall of a cell, it's going to bleed out, essentially. It's not blood that it's losing, but it's going to lose its fluid volume. It's going to lyse, it's going to rupture, and either absorb too much fluid and make it kind of blow up, or it's going to shrink it down because it created a leak. So one of those two ways will affect the ability of that invading organism to live for very long. So that's our complement protein job. And then the phagocytes will come in and clean things up. Now our antibodies themselves, we've got a number of different types. And so collectively they can call them immunoglobulins. And we've got kind of 5 primary classes. The IgG, or the gamma globulins, are the ones that have the largest number of general antibodies, and those are what we typically have the most of in our body that are trying to fight off invading bacteria. Some of the other ones have other properties. The IgE, those are the ones that we typically see with like allergic reactions. We see too many of those released. But we have tons and tons of antibodies, 10 to the 20th power of antibody molecules that all of us have. So we've got a gazillion different antibodies that we can recognize. And it's just a matter of, if we've been exposed to that organism first, how quickly we can ramp up a response to that invading organism. But our IgG is the main type. I think in pathology, we had a discussion about this on the, when we went over the immune system there in infectious diseases. And somebody had mentioned that their sibling had gotten an accidental needle stick and then had to go get treatments for a period of time afterwards. And usually what they're going to do is give people IV doses of these gamma globulins so that they get extra antibodies so that they can potentially fight off whatever might have been introduced in their body through that accidental needle stick, whether it's like somebody that was HIV positive or somebody that was hepatitis B positive. we want to kind of help that person's immune system do its job a little bit better. So those are definitely a critical one for healthcare workers to kind of be aware of. All right, so there's our complement system. And if you look down at the very bottom, these are going to work through proteins that basically break apart the outer cell covering of the virus, of the bacteria, of the fungus, whatever organism it is that's trying to attack us, so that it's going to rupture that cell and it can no longer be viable and reproduce and wreak havoc in the body. So we like the complement system that helps those things out. Now our T cells, we've got our helper T cells, and those function more like a B cell, where they're just about identifying the invading organism. Our cytotoxic T cells or killer T cells are going to function more like the complement proteins. They're going to have the ability to basically poke holes in the cell that's invading us and make it lose its fluid or absorb too much fluid and essentially rupture it. So they use an enzyme called a perforin that basically perforates the cell wall and causes that destruction. Let me skip that one. Let's see, 10:13. I got 7 minutes. Okay, so I'm not doing awful. I would like to be farther, but it's not awful. So our friend Hank mentioned the MHCs. And so the MHC is on our body's own cells. We're going to have a distinct MHC marking, and that's our own personal antigen that makes our cells recognizable as our own cells. And so I mentioned how when if an organism is able to get inside a cell and start multiplying inside that cell, then the cell loses the ability to put out its own antigen. And if without that marker, then when a T cell comes along or an NK cell comes along, they recognize, hey, this thing, it looks kind of like our guy, but it's sick, and we don't want that sick thing around, so we're just going to sacrifice it, and they will basically destroy our own cells appropriately if that cell is sick and damaged. And that MHC identifier is what we have to worry about when people are going to get an organ transplant. So if they're getting a kidney transplant, a liver transplant, a lung transplant, any of these, some of the more common type of organs that get transplanted, that's what they're worrying about matching. And you always hear about, oh, they have to wait for a perfect donor that's the perfect match. It's that MHC marking that is what makes the body able to accept that new person's organ into somebody else's body and not attack it. And if it doesn't match, the likelihood that that donated organ is going to survive and function in the new person's body is next to nothing, because we can't create a strong enough immunosuppressant response to keep the organ that was donated without also affecting the overall effectiveness of the immune system and making that person very vulnerable to infection. Even with transplants that match, patients usually have to take immunosuppressive drugs to try to tamp down that immune response so that it doesn't attack that donated organ, because they're really hard to come by, and we don't want them to get wasted by putting them in the wrong person's body. So the MHC part is the key for that.
Hey, Craig, on the MHC, like in autoimmune diseases where your body is attacking its own cells, like, does that have a role in that?
I think it does. I think it's essentially that the attacking cells fail to recognize that that is actually one of the body's own cells. So it's like it doesn't recognize the MHC as being the correct one. It must view it as being the not correct one for some reason, and mounts that response. So it is. I think there's different types of autoimmune reactions that we can have, but for at least one of them, I think the more general autoimmune dysfunction is that those immune system cells don't recognize the body's own cells and start to attack them and cause that problem. All right, we probably have time to go through this and then we'll stop here, I think. So this is, in the blue line here is our primary response when we get exposed to an invading organism. The secondary response is what we would see either if we got exposed to that organism again a second time, months later, or if we've been immunized against something. So a couple years ago, I got the flu, and I had not gotten the flu shot. And so I was kind of like this primary response. That organism came in. I wasn't able to quickly enough identify that it was an invading organism and mount an effective response against it. And it let that infection spread enough to the point that I got lots of symptoms. I had body aches, chills, fever, felt really blah, lethargic for the better part of a week. My wife had gotten the flu vaccine that year. And so when I first started feeling sick, we were down in St. George and we drove all the way back in the same car, sharing airspace for a pretty good while. And she got sick just briefly. She had like a much more mild fever than I did. And then felt better within 24 hours, whereas I was sick for the better part of a week. So because I had not taken the flu shot that year, I was kind of down here at this blue line. Nothing really happened for the first week. Finally, once I started having all these symptoms and I get this more generalized, raise the body temperature, see if that works. These antibodies we don't have enough of them to really be effective. It took me a while to beat back that infection and kind of regain control of my body. In the case of my wife, she was more this pink line. Yes, I gave her that bug, I'm quite sure. She had the response, but she already had the antibodies present in her body to immediately start making more of them and create a big enough response that she could fight off those things and minimize her symptoms really quickly. So when we get vaccinated, we're trying to induce this secondary response so that if we do get an initial exposure, we're already kind of geared up to fight it, as opposed to somebody that has never been exposed to it, then they're going to do this. And with the coronavirus, because it was so-called novel, nobody in the human population had created the antibodies against it yet. That's why it's able to wreak such havoc and get spread so easily. So hopefully once we get the vaccines out in public and get enough people vaccinated, we can have enough people that are able to tamp down the illness and not allow it to multiply and spread as effectively. So that's kind of what we're hoping, is we're trying to generate that secondary response in enough people that we can minimize the spread and regain control and get our lives back to normal at some point. All right, so it's 10:20. So I think we'll stop there. We'll have a little bit left to talk about these different types of immunity. The second video did kind of talk about most of these. But we'll talk about both active and passive immunity and kind of finish up this chapter, and then hopefully have the bulk of the time on Thursday to go through the respiratory system and kind of how that all works. All right, last minute questions before I let you guys go. All right, so start looking through the study guide. That way if you have questions for Thursday, I'll be able to address them. I'll have office hours next week on Monday before the test. So if you end up studying over the weekend and have questions on Monday, you'll definitely have a chance to ask me about that during those hours if you feel the need with that. But otherwise, we just have the rest of this content and then the pulmonary chapter to cover. So have fun in Kines. I'll see half of you this afternoon in lab.
Can I do some muscle pass offs?
Yep. What are we working on?
We're doing the leg, like
Okay.
the lower part of the leg. So I'm going to start with the flexor hallucis longus, and that's on the posterior fibula and the interosseous. I don't know how to say that. Interosseous membrane, and it's the distal phalanx of the great toe, and it flexes the great toe and assists in plantar flexion and dorsiflexion. And it's the
well, we'll do plantar and dorsey.
Oh no, it's no, it's inversion.
Okay.
right? It's inversion, right?
Yes.
And then it's the tibial nerve. And then flexor hallucis brevis. It's the plantar surface of the cuboid and the lateral cuneiform bone.